You're a loser. You're a freak. All they did was point at me and laugh. I'm inviting everyone to my party, but not him. This is bullying. What if I told you that those kids you bullied, called names at, and the ones you didn't stand up for are now suffering from a range of poor health outcomes? So what makes someone a victim to bullying? Why someone is bullied can come down to a wide range of factors. Many of these are shaped by the conditions in which someone is born, grows, and lives. These factors are known as social determinants. As we can see here, social determinants play a role on both sides of bullying. Race, economic disadvantage, occupation, and social exclusion can influence why someone may be bullied. In turn, bullying can act as a determinant for poor health and other vulnerabilities. This essentially is a complex and multi-directional network of associations. There is substantial evidence surrounding the impact childhood bullying has on the individual in their early life, but little knowledge on whether the effects of bullying persist beyond and into one's midlife. As a result, a study was conducted to explore these midlife outcomes of childhood bullying. To explore further, I'm going to interview Barbara Maughan, who was a part of the team that conducted a 50-year-long research into the health outcomes of childhood bullying. Hi, Barbara. From reading your paper, it is clear that bullying did extend and impact much further into one's adulthood. Can you explain how your research was conducted?
Having me. To fully understand the impact of bullying, one must assess the short but also long-term effects. Our research involved those who were bullied at age 7 and 11, and then we did a follow-up assessment between the ages of 23 and 50. We first assessed factors that led to childhood bullying, exploring social determinants, family social class based on father's occupation, parental involvement, child's IQ, and other childhood adversities such as poverty and violence. Adult outcomes explored psychological distress at age 23 and 50. The participants also evaluated their general health, were involved in a cognitive function test at 50 and additional socio-demographic indicators including educational qualifications, partner status, employment status, and weekly net pay. All of these indicators contribute towards a comprehensive understanding of bully victimization, and in particular, its association to poor health outcomes and social vulnerability.
Yes, your research definitely explores bullying as pervasive, contributing to many spheres of one's life. As you stated in your paper, bullying does not operate in isolation, and I feel your results reflect this, as they are greatly associated with a range of social determinants. Do you feel this is the case, Barbara?
I do. It was clear that childhood bullying is detrimental and leads to poor health outcomes. In particular, there was an increase in psychological distress and heightened vulnerability in depression and anxiety, even 40 years after exposure. But the results are not limited to health. Being bullied was linked to being male, having parents in manual occupation, low parental involvement, and experience of 2 or more childhood adversities. Furthermore, assessing midlife of those frequently bullied showed adults to have lower levels of education, social relationships with increased risks of having no partner at age 50 and less likely to have social support. In understanding this greater picture of bullying, we can essentially say that social determinants frame outcomes before and after exposure of bullying.
Risky behaviours like smoking, substance use and alcohol are seen to be associated to poor health outcomes. One would think that victims to bullying may turn to alcohol abuse as a coping mechanism. Is there any evidence to support an association between bullying and the increase in risky behaviours that may in turn lead to poor health?
We actually found that bullying victimization was not associated with increased risk of alcohol dependence. Other behaviours were not assessed in the study, but many need to be considered in future studies as they could be underlying causes to poor health outcomes.
So, how important are these associations, and how will they impact on healthcare and addressing health disparities?
These associations are critical as better health is seen to come from action on social determinants. Essentially, addressing social determinants may reduce the overall health burden. We have recommended interventions that aim to reserve the effects of early adversity to hope to minimise poor health outcomes. These may also help prevent problems that were seen to persist into adolescence and adult life.
Thank you, Barbara. I love how you say that better health comes from action on social determinants. This study has definitely provided an insight into how one issue can encompass a range of other factors and essentially establishes how complex issues can become. There is a needed consideration of social determinants in all areas of health. Could they possibly be the solution we need to stop bullying?